patiently waiting for us to get started, but we're extremely excited that all you guys helped to make our evening here tonight. As you can see from our poster, our moniker is Live Beautiful, and our philosophy with that has been over the years to try to do the best for our patients, both on our medspa side and on our surgical side. But with the debut of hormone replacement therapy and wellness, we're going to help you to live beautiful both on the inside and the outside. And it's similar that I'm sorry. Louder. Okay. It's similar to when I would do facelifts on patients that don't do any skincare, and you're just lifting up skin that has a lot of sun exposure. So then we would help them with the spa side. Now we're going to help both the surgical side, the spa side, and then the insides part. It's interesting. I'll introduce our speaker here in a minute, but our business associated with a management group last year called Cosmetic Physician Partners. And we've got the CPP Dream Team here helping us with this, as well as our staff. Blair here in the back. And Justin, are you back there somewhere? Yeah. So, but they're the marketing group for CPP. And so we have what's called a boondoggle every year, which is when all the different practices all across the U.S. get together and talk about our business. And this year, our boondoggle had a special guest that does hormone replacement therapy from Dallas. His name is Dr. John Pete. And Dr. Holt just recently spent the last weekend with him in Dallas. And when my wife and I were there, Catherine was there for the meeting, we did a big session with Dr. Pete, and that's his special. He's been doing nothing but this for 13, 14 years. And he asked everybody in the audience about, for example, women, when do you first start noticing loss of energy? When do you first start noticing hair loss? When do you first start noticing decreased sex drive? And my wife immediately said, when she gets married. But so, and she meant to say it quietly to me, and then the whole side of the room heard her say that. But we really think it is. I mean, obviously it's important. You guys braved the rain getting here tonight, and it's going to be a complete, I think, total patient care kind of situation going forward. It really is pretty easy, but I mean, it takes some evaluation and tweaking of all the different parts of not just hormone replacement therapy, but all the wellness side. We are very lucky in Eugene to now have Dr. Beth Holt. She's been here for a few months now. She is a naturopathic physician and has been doing hormone replacement therapy since 2017. She graduated from Sonoran University of Health Sciences with her doctorate in naturopathic medicine, and has done many hormone health medical aesthetics. She's taught a lot of the courses on cosmetic injections, Botox, fillers, that kind of so she's kind of like the total package here, I think. So I am so lucky to have her here, and I'll kind of turn it over to Dr. Beth Holt and our special VIP guest, Chelsea Duke. So many of you know Chelsea. She has Glow Yoga here in town. Shout out. And Glow Yoga is, it's great. I work out with a trainer a couple times a week when I can, but exercise can only take you so far. Eating well can only take you so far. So I think it's pretty easy to do just that last little thing that can really turn your life around. So with that said, I will.
Mic transfer. Okay. Thank you. Well, welcome everyone. I recognize a few faces in the crowd. You're my peeps that I see once a week or every so often for injectables. So thank you so much for taking the time to come and learn about what we have to offer. I wanted to start out with a fun little exercise, which you didn't know is you took a test already. So I was curious, maybe prior to doing this intake, tell me what are some symptoms that you think of when you think of menopause? Just raise your hand.
And repeat the answers.
Okay. Anyway, I heard hot flash by the people who work here. That doesn't count. But what else? What else? What would be another symptom you might imagine?
Dryness
all over. That's right. And to piggyback off that, we think of, oh my goodness, you spend all this money with our advanced estheticians doing laser with Jose and so on and so forth. But if we don't have estrogen on board, we get dry skin everywhere. What else? Anything else? You won't be judged. It's okay.
Hair loss.
Hair loss, 100%. Yes. What else?
Decreased energy level.
Decreased energy.
Well, prior to going into menopause, I did not think this, but my biggest concern now has been achiness.
Achiness. Thank you. If I had stars, you would get one. So one of the fun things we learned at this training I did with Dr. Pete this weekend is the number one complaint for males and females once their hormones drop off is that testosterone depletion causes body-wide pain. And they're actually beginning to start testosterone replacement therapy for folks as a pain management resource. That's a really good one. I wasn't expecting anyone to say that, so thank you.
Well, we had a little.
We had a moment. Okay. Okay. Anything else that stands out? Okay. Night sweats. Absolutely. Well, some of the other key ones that we don't necessarily think of are weight gain in the abdomen is a sign of estrogen depletion. Brain fog is an estrogen depletion symptom. Body tired, kind of like you have brain tired versus physical exhaustion. Brain tired is more of our estrogen. Testosterone is more of our body-wide tiredness. And other things we don't think about is estrogen is protective to our bone health. Testosterone is instrumental in your bone density and your cardiovascular protection. The leading cause of death in females after menopause is heart disease. So your estrogen is protective to so much more than this isolated thing, which is hot flashes. That's like kind of the one that gets the most publicity. So part of this evening and why we have this beautiful patient model here is that we wanted to kind of shed light on the fact that these issues typically start for patients actually starting at 30 years old. We start losing testosterone levels at 30. At 40, you begin losing your progesterone. And then by 50s, estrogen is offline as well. And sometimes that can present in odd ways that we aren't thinking about. And there is a little bit of a lack in the conventional medical model, and we're not here to bash anybody, but it's a disservice to patients how little labs are ran by your gynecologist. And they are not, and this is something Dr. Pete said during he's an OB-GYN, they do not receive hormone training in school. They seek it on their own if they choose to. And so if you're experiencing hot flashes and you think, oh, well, my gynecologist would be who I speak to, half the time they're not even well versed on that particular matter. So moving forward, we were going to have a little chit chat with Miss Chelsea. And why don't we just talk about what brought you in?
Yeah. So I am an actual patient of Dr. Holt's. I'm not 30 years old also, which is sort of what it sounded like.
Oh, sorry.
I wish. I'm 40. But I have noticed, so I have a yoga studio. I would consider myself extremely healthy in lifestyle. And as Dr. Daniel said, I have been noticing some symptoms, and I was unsure if it was premenopause or something else. But just feeling some things that have shifted and changed recently. And I felt very uneducated and uninformed. I didn't understand what options I had or what I could potentially do. I also wasn't sure if I was just supposed to accept not feeling optimal as I get older and experience some of these premenopausal symptoms, or if there was anything to be done. So we started having that conversation, and I have learned so much, which is really exciting. I think we're going to go through that today, and I'll let Dr. Holt speak to it because she's the expert. But I basically just wanted to gather some data and information with lab testing and having a conversation about symptoms that I'm experiencing and things that I'm noticing shifts and changes in, and just seeing again, like, is this something that should just be accepted, or is there anything that we can do to help minimize some of these symptoms and support this transition that I'm beginning?
Yeah, and please, if you are open to it, tell us a little bit about what symptoms were you experiencing?
Yeah, so I'm a complete open book. So she's like, whatever you're comfortable. I'm like, you can share all of my labs. I totally don't care, because I just feel like there's this cloak of like, I don't know, secrecy with this information. And I just, like we were just saying, I was like, I feel like I'm entering this era as a 13-year-old girl getting her period for the first time, where I'm like, what happens now? Like, what do I do? And everyone's sort of like, I don't know. My friends don't know that are going through the same thing. So for me, and this is, I think, maybe unique, but what initially drew me to this process, I'm experiencing some like really irregular period things going on for the first time after years and years and years of really regular cycles. So lots of bleeding, like shorter cycles, so longer times bleeding. And for me, that was impacting energy a lot. I mean, and probably we discovered something else that is happening was also probably a factor with the energy, but it's something that I noticed a significant difference in. And I, as someone who is so active, I exercise for my job. I really have to be in optimal energy. And so that was my biggest concern that I wanted to kind of figure out. And again, just not knowing if it's like, I know that things are going to shift and change over the next 5-10 years, but I didn't know like how much change I should be like, should I accept that I'm having my period like 50% of the month? Or is that something that probably is not, which you should not accept that, I learned. But I did not really know. So yeah, that was kind of the main thing.
Yeah, and so as I mentioned a moment ago, the primary hormone that drops at 40 or around that time is progesterone. And so in a normal cycle, your progesterone will elevate at the back half of your cycle after ovulation, and then that drop in progesterone is what causes our menstrual period to happen. And in your 40s, you have now lost a good portion of your progesterone, which is the explanation for why Chelsea was having all this breakthrough bleeding that really shouldn't have been there. And it's a simple fix of, we will be replacing her with some progesterone therapy. And there's other benefits to that hormone, which I wanted to say. It has a wonderful calming effect that helps us sleep at night. So it helps improve sleep quality. It's protective to our breast and uterine tissue. It helps reduce bloating. Actually, it's a big helper for females who experience migraine. Progesterone is a great migraine treatment. And helps control things like uterine fibroids. So same thing for folks who are having tons of bleeding from uterine fibroids that are out of control. Progesterone therapy helps that. And then it actually increases memory. Yay. So, and so one thing I like to point out at this point is, for Chelsea's age range, the usual therapy, if you go to the primary care or gynecologist, is usually just to put you on birth control. And that has a whole nother set of risks and isn't always bioidentical hormones. So that is why I do what I do, and now get to share that excitement with you guys. So anything else?
Actually, the other main symptom that I was experiencing that was happening at the same time that this shift was happening was some anxiety, which is not something that I'm used to experiencing at all. So that was another sort of like red flag. I'm like, these are both increasing at the same time. I just felt like it was probably hormonally related. So that was another kind of contributing factor to figuring this out.
Yeah.
Yeah.
So from here, so Chelsea came in, I got her health history. I understand what's been going on with her. The first visit, we just have a real nice deep dive discovery. We actually usually take 30 minutes to 45 minutes, which is a really thorough, long doctor's visit. And from there, I order a lot of labs. We actually use a specialty lab company that allows us to get excellent pricing for the number of labs we run. And something that's important to me as your naturopath is I want to see the whole picture. We're not isolating just your estrogen, just your testosterone. I'm not only looking at a part of the thyroid, I'm looking at all of it. And Chelsea was kind enough to let us show you her results. So we're going to do a little blood review, and I'm just going to explain to you guys what I see when I'm looking at those labs and how it translates to how you're feeling.
Yeah, that's
So,
great.
okay.
Yeah, and just quickly to touch on the process with the appointments, there was so much in-depth conversation, back and forth, questions, lifestyle questions, symptom questions that I didn't even know I needed to be talking about. Like, it was just really, I felt very understood as a whole person, not just with the specific situation. So I was really appreciative of that.
Cool.
Yeah,
Thanks.
that's great.
I am not techie and don't know why this isn't up here. Sorry. I feel like we got it up earlier and I don't know what I'm not doing. Oh, that's it. Cool. No, I don't know why. Does anyone have questions while we're or comments? Anything to add? We're an intimate group. Okay. Can you guys see this okay? Ish? How's that? Okay. Right. Okay. So the first thing I like to look at for my patients is your nutrient status. A lot of fatigue symptoms surround basic stuff. We always said in school, naturopathic medicine is not sexy. I'm going to tell you to drink your water, take your vitamins. I want you pooping every day and sleeping 8 hours at night. Literally the pillars of health. So one of the things, especially for a female who's having heavy menses, like a lot, we want to check on her iron status. So first and foremost, I'm checking in on a full iron panel. So up top, we have what's called ferritin. That is your liver storage of iron. So that's your backup storage. She actually has a nice robust number. I like that to be close to 70. But what's interesting about my athlete over here is her total iron is 159. So this is your backup storage in the liver, and this is the stuff floating around in the bloodstream. And you're thinking, well, what's the deal? She has heavy menses, losing lots of blood every month. Why is her iron high? And we sort of came to the conclusion that it's possible one of the athletic greens she was taking had spirulina powder, which is an iron containing supplement. So as doctor, you're playing educator. That's our role. Doctor in Latin is docere. Docere is teacher. So our job is just to show you what's going on under the hood, and you take with it what you can, and we come up with your plan. Anyways, but the key here is we're also playing an investigator. So I'm thinking, okay, iron, we can check that off the list. We're not depleted there. But then we look at her folate, vitamin B12, and vitamin D. Surprise. I want your vitamin D to be 75 to 80. Okay, so what I learned, I actually looked this up in a conversation. The UV index needs to be 3 in order for you to actually make vitamin D from sun absorption. And in Arizona, where I'm from, that only happens from 10 a.m. till 1 in the afternoon. What are we all doing at that time of day? We're at work, we're inside. So our people who live in Eugene, Oregon, I don't know if the UV index ever is 3.
It's never been 3 here before, ever.
Yeah. And so what we do for this, most vitamins on the market are only going to have 2,000 IUs or international units or 5,000. I just learned this weekend at my course with Dr. Pete, and this is something we've been doing in practice for the last 8 years. We actually temporarily put you on 10,000 IUs per day for about 6 months to get that number up. So that alone, vitamin D actually functions to support your immune system. It functions to help with your mood and weight balance. So we're just going to see if that alone just gives you some changes. And remember, my job is to make you optimal. I'm not here to just keep her alive.
Right.
We're not in the emergency room. I'm here to be taking her body to the next level. Yes.
Yeah.
Can you clarify what the red means? Does it mean too high, too low, or just pay attention to it?
Oh, good question. So over here on your labs, you will get a little reference range. So all the little blue dots are where her labs fall. She wants to be in the green. For the vitamin D case, she's too low. So if you're too low, can you see that? Okay, here, let me go way.
The iron being too high and then the D being too low, is that?
It was on the other side of the.
Yes, and it's out of that optimal range.
Okay.
So the green value, thank you for asking that. The green little bar represents what's the normal range. And then I tack on, okay, fine, but I want you optimal. So I usually write on your labs when you're in clinic with me, hey, your vitamin D might be, where did we go? Vitamin D might be normal at 30, but I want it at 80. Right? So that is specifics that we go through together when we review your labs. Okay. So we got to do some good basic nutrient supplement, vitamin D. That's kind of part 1 of our protocol. And then,
well, and can I just interject quickly?
Yeah,
I find this so
please.
valuable because I do eat like a very nutrient dense diet. I'm super conscious about the food that I consume, and I consider it very healthy and balanced. And to know specifically what is not working in my body or what I'm not getting enough of, I think is so valuable, because it's not just about taking random supplements that like your whatever are marketed to you or whatever it is. Like, I think having the data of understanding exactly what your body actually needs is something I was super excited about.
Yeah, absolutely. And it helps in other departments you might not think of, like bone density, you know? Okay. So first part of the puzzle we talked about is nutrition. So now we're going into what's cardioprotective, what's protective against diabetes, dementia, and all chronic diseases, which I call sort of the triad. And that is going to involve fat in the blood or cholesterol, sugar in the blood, and inflammation markers. So this would be part of your lab panel should we do this in clinic together. So the top 2, I have to kind of wiggle around, so I apologize about that. But this value here is called C-reactive protein. Chelsea is a beautiful example of good health. And her C-reactive protein is only 0.2. I want this below 0.9. So that's your inflammation marker. And then I'm about to show you the second one, which is her homocysteine is only 6. That is wonderful. Usually, when patients do not take care of themselves, these values go up. They tell me things like if you're vitamin deficient, if you're eating poorly, if you're stressed, if you're fighting off some chronic disease, all kinds of stuff. So we look at the first part of the triad is inflammation. Then I move to cholesterol. So we've all seen this before, right? The doctor says, let's check in with the cholesterol. So her total cholesterol is 175, A plus. I want that below 200, yay. Her LDL, and I say double L, go to hell. That's a bad one. I really do. I say it every time. That one is nice and low, below 87, or excuse me, it's below 99. Hers is 87, lovely. Then her HDL, H is for heaven, we want that to go high, is 72. It is so lovely that these two values are almost matched. They're almost a 1-to-1 ratio. This is anti-inflammatory. Your HDL acts as a scavenger molecule and it gobbles up all the cholesterol we don't want around. And when you think of what to eat to get improvements with HDL, and I know she eats it because I watch her Instagram, it is like seeds, good fats, fish, poultry over steak, that type of stuff. And then moving forward, we have her triglycerides, which are nice and low, all great for heart health, good prevention, and so on. Now, it could be that she maintains this because she's an athlete. Truly, this woman works out multiple times a week, eats perfect, all the things. But after women lose their estrogen, sometimes these values go wonky. So it's important for us to screen now just to get a baseline to see, okay, where was she at when her estrogen was online? And then once it goes away, did they change? And then the third component we mentioned for the triad, remember we went over inflammation in the blood, fat in the blood, and now we're looking at sugar, is I look at your hemoglobin A1C. That's your 3-month report card of where your blood sugar is. So it's like a snapshot in time. HbA1c is what your doctor looks at when they're screening you for diabetes. So any value above a 5.7, I'm yelling at you to go to the gym and eat better. But she doesn't have that problem. We're at a 5.5 here, which is lovely. And then I take it a step further and we look at how the pancreas is secreting insulin. Because remember, insulin is your signal, hey, I send insulin into the blood. It attaches to a little receptor, and then the receptor opens the door and sugar goes into the cell and is used. If you have tons of insulin floating around in the bloodstream, it's creating inflammation in the artery. It's also causing scratches in the arteries, and then cholesterol packs the wound. So when you think of heart health, cholesterol is the one getting all the publicity, but why aren't we talking about the sugar that's out of control that's causing the injury to the vessels that ultimately leads to the plaque buildup and things like that? So any questions on what we've talked about so far? Are you with me? Am I losing you? Okay, cool. No.
In summary, no sugar.
No sugar. Okay, so this next one, I will give a very brief overview. We'll definitely go over it a little more in depth in practice or what have you. But basically, when you go to the doctor, they always run what's called a comprehensive metabolic panel. This is basically showing me your kidney and liver are functioning well. There's no liver enzymes that are elevated from too much of, alcohol consumption. And I know when you tell me you're not drinking, I know. And so that is basically what this is. So the top portion is her electrolyte balance. She had a little elevation in her chloride. I suspect if we ran this value again, it would just re-regulate itself. So I'm not super worried about things like that being off just by a hair. And then we look at her kidney values in the middle. She has beautiful filtration rate in this value here. We're looking at glomerular filtration rate. That's just saying all the fluids are going through the kidneys as they should, no concerns. And then I kind of breeze over her liver enzyme. Those are the ones. They're the ones that get them in trouble. But I want her ALT and AST to be as close to 20 as possible. Okay, so awesome. We've looked at nutrient status, we've looked at inflammation, cholesterol, blood sugar, and her organ function. We are doing great so far. Now let's get to the good stuff. Okay? So now we're here at the beautiful thyroid. How many people have had their thyroid checked? Yes. How many people did anyone talk to you about your labs? Like, did they explain it? Do you care to share a little bit or anything?
Well, it was interesting because my PCP, so.
Oh, I'm sorry. Let me get you the mic if that's okay. If you don't mind.
I would get up.
No, that's okay. So you went to your PCP.
So I'm 54 at 44. No, maybe 42. I'm looking at Tracy because she probably remembers.
Mm-hmm.
At maybe somewhere between 40 and 42, had not gone through menopause, was not having necessarily symptoms, but was experiencing fatigue and reported that. Nothing happened. Reported it to my gynecologist, who my PCP was a woman, by the way, and my gynecologist was a man. And he said, let's test your thyroid just for fun. Humor me. Let's test your thyroid. And as it turns out, I had an underactive thyroid. And so started me out on a very small dose of 50 micrograms, I think at the time. I think I'm up to 75 micrograms now, 10 years later, and it made all the difference.
Awesome.
All the difference. And he sat down and he explained to me what it means and what are the values and the things I could be doing to be helpful. And if I ever wanted to get off of levothyroxine, what could I do to make that happen?
Mm-hmm.
And was just super, super helpful. But never once had a conversation with my PCP about it. Interestingly enough.
Thank you. Thank you for sharing that. Cool. Well, let me get mic'd up and then I'll continue.
And it
here.
did change from 50 to 75 when I hit menopause.
Yes, I'm happy you mentioned that as well. So what's interesting, when we think of the receptors for hormones in the body, oh no. When we think of receptors in the body for our hormones, what's interesting is the most receptors, like from head to toe in the body, are for thyroid hormone, which that was even news to me. That was a new pearl I had. Thyroid is the body's thermostat. It is upregulating how many calories we burn. It downregulates your calorie burn. And what that means is if you're in a time of stress and you need to be prepared for the famine, because there will be no buffalo for 4 months, your thermostat goes down and it makes the thyroid sleepy and not burn as many calories. That has to kind of involves our basal metabolic rate, which is your calorie burning. So when people have thyroid issues or hypothyroid, they feel cold, their hands are dry, they lose the outside portion of their brows, they have thinning hair. I think I said they're cold all the time, and they're constipated and they get weight gain. Often the doctor will only run one value if you're lucky, your PCP will run a TSH. Well, what we learned at the advanced training last weekend is this value is only a reflection of what's going on at the level of your brain. Now remember, you have receptors from head to toe. So if you're only testing what is happening at this level, what about everywhere else? And so often patients are struggling with hypothyroid and they're completely underdiagnosed. The other key component, which we did for Chelsea, because and we'll get to her lab values in just a minute, is the thyroid loves iodine. It needs iodine in order to create the active thyroid hormone. And in Japan, what are they eating all day? What else? Seaweed, yeah, baby. So that's full of iodine, packed with it. They're getting something high like 12 milligrams. Our supplements in the US usually have like 100 micrograms, like not even cutting it at all. So you need iodine and selenium to produce the proper thyroid hormone, which is an easy fix. That's something we can just, toss into the daily routine. Okay, let's get to the good stuff. So first we start out with the signal from the brain, which stands for thyroid stimulating hormone, or TSH. That signal then goes to the thyroid gland and it says, hey, make thyroid hormone. The higher that number, the louder the brain is like, yo, make me some thyroid hormone. And so when you have a value that is creeping above 4.9, your doctor should be putting you on something. But I would argue that anything high above a 2.5 is like you should probably start intervention sooner. So sometimes patients aren't officially diagnosable for full-on hypothyroid, but they would benefit from a little bump or support. And what we do is we make sure we check in on the patient's symptoms. It's not isolated to what the blood work says. Okay. Anyway, so let's kind of breeze through this a little faster here. So TSH sends the signal to the brain to make T4, which is your thyroxine. I want that value to be nice and close to a 7. Chelsea's was at a 6.5. Awesome. Close enough. Then the thyroid gland uses iodine to make free T3 and free T4. And I want your free T3 to be close to 3. So she was at a 2.5. So just pretty close. And I want free T4 to be a 1. And she's right on the money. So in my mind, I'm thinking, okay, Chelsea has not complained to me of a weight issue. There's a little bit of fatigue. Thyroid could be part of the problem, but I want to look at the rest of the story before we make that judgment of, does she need thyroid hormone? I don't think she does. We're going to do a little thyroid support to get her started. And then the only other thing I wanted to mention on here that we didn't touch on yet is these little guys. So when you do have thyroid hypothyroid, there are 2 things that can be elevated in the blood, and they're oh, we need someone to go to the we're not live or anything. Okay. So that was awesome. Okay. So thyroid antibodies are anti-TPO antibody and anti-thyroglobulin antibody. Why this is relevant is sometimes you will have a perfectly normal thyroid reading at the doctor, but you'll have elevated thyroid antibodies, which means you have little immune cells that are waiting in the wing to attack the thyroid gland or the thyroid hormone that you are making. So it might not be an issue now if these were elevated and the other labs were normal, but it could be an issue down the pipeline. Does that make sense? Okay. So Chelsea's labs do not indicate she has elevated thyroid antibodies, but it is nice to have for me to see, okay, this is not a problem for this person, and this is things I run routinely when assessing thyroid. Okay? All right, we're getting to the grand finale. Questions at all? Okay.
Yikes.
Cleansing breaths. No. I'm just talking a lot. Okay. So then, last but not least, we have arrived to 2 other parts of the endocrine system. So we've already talked about the pancreas, which makes our insulin. We've talked about the thyroid that regulates our calorie burning and energy. And now we're down to the ovaries and the adrenal glands that sit above the kidney. So when you still have your ovaries prior to menopause, your sex hormones are produced in the ovary. And once menopause happens, then your adrenal glands take over for the ovaries. So you still make a little bit of estrogen and testosterone, but it's just a small fraction of what those little ovaries were doing. And the other time where we run into menopause, sometimes prematurely, is if you have a complete hysterectomy and ovaries are not saved. So sometimes folks have to have their ovaries removed too. Okay, so that is where we're about to start investigating for Chelsea. Does anyone have questions so far? You guys are so easy. Okay, cool. So first things first is we start at the brain and work our way down. So for her, we look at FSH and LH. When you're cycling still and get your period, FSH is follicular stimulating hormone, and that is what signals to the ovary to mature your egg. Then LH, luteinizing hormone, is surges, and that tells the ovary to release the egg, and then fertilization can occur. FSH is our big marker for menopause per the blood value. So hers is cute. It's just a 3.9. But anything above a 20 is diagnosable for menopause per the lab. But your doctor will say, hey, you need to not have a period for a whole year before I give a crap about you. But if I run your lab, or if we look at the whole picture here, and your FSH creeps up to like 18 or 19 or 20, I'm like, oh, wait a minute. Your brain is like, ovaries, make more hormone, right? It's a louder scream. So that's where I'm looking at for Chelsea. I'm like, okay, where are we at? Does she have some premature ovarian thing happening where she's going into menopause really early? And that was not the case for her, because then I go up to her estradiol and she has plenty. A value of 238 is beautiful. So then I say to myself, okay, now what? We move down and we see her testosterone. So remember, the ovaries make the testosterone as well. So her total testosterone is 19, and her free testosterone, which means it's available in the body to do its job. Just because she has a 19 doesn't mean her body tissue is able to access it, because sometimes, it's usually transported in the bloodstream bound to a hormone protein called sex hormone binding globulin. So it's like, here's your testosterone molecule, it's bound to a little protein, and it's not able to do anything, okay? So the free testosterone for husbands also is very important, not just the total, okay? So in my world, a testosterone less than 20 might as well be 0.
Womp womp.
And
What's the target?
and so the target for testosterone total is actually 70 to 100. Now, that's can be hard to achieve at this age without supplementation, but I've found, and a lot of our colleagues in this industry find, that females feel the best around 70 to 100, and you could go as high as 150. And that's the age our testosterone can very well be, when you're like 20. So our bodies are used to having that kind of testosterone around. Men, I want it to be 700 to 1,000. So your man with a low T of 250, he's being a pain in the ass for a reason. So that's the key. We might want to help her with a little bit of testosterone replacement. Now,
I think you need couples.
Yeah, I know.
Actually,
I never even asked you this. Do you do this whole process for men also?
I did it this afternoon.
Okay.
Yes, I do. So, and guys are really fun to work with too, because they're so easy. They're just, you just say, go do this thing, and then they do it.
do they know?
But why?
Wait a minute.
Depends on the thing. Depends on the thing. Okay, at least I think they do. Okay, so remember that transport molecule I was telling you about, the sex hormone binding globulin? Look at where hers is. 128 on the high end. So that means of that little 20 testosterone, her total testosterone of 19 is 100% bound up by this guy. Do you see what I'm saying? So it's like even this poor woman who is burning the candle at every end is suffering testosteroneless. So our testosterone, I know you would think, okay, libido, orgasm, things like that. But it also is your muscle recovery post-workout. It helps you build bone density. It actually has been proven to be protective to your breast tissue. And it helps with your go-go juice. It's like, okay, let's get the shit done. Testosterone. Do you know what I mean? Yes.
How are you replacing the testosterone?
Good question. So in this case for Chelsea, we are doing a little bit of cream, and that allows her to have a little bit at a time, and we have control over how much she's getting. Meaning, if she's on it, we try this low strength for so many days, and she's like, gosh, Dr. Holt, I'm really not feeling this. We have the option of going higher or lower, and that gives us lots of control. Other options for testosterone would be you could do an injection, and then we also offer hormone pellets.
Because I will tell you, I'm looking at, I've been doing my blood.
Yeah.
Mine right now is at 20. My GP, my OBGYN, and my thyroid doctor are like, it's too high. It's too high.
Out of 20?
20.
Really?
It's like, it's all, everybody's like, it's too high. You got to stop. It's in the red. I'm so frustrated.
Interesting. And my curiosity would be if I were able to like have lunch with those particular humans, why? Like what is the fear? For females, the testosterone once again is protective to our health. And the only concern sometimes you'll run into is it stimulates the bone marrow to create more red blood cells. So I know there's bad publicity around it causing blood to get thick and sticky, but it does not. It is actually telling the body make more red blood cells, similar to athletes coming to high elevation, places to run and train. And that helps boost those red blood cells the same way for increased oxygen carrying capacity. So anyways, and what's interesting about that as well is the high end of normal is 185. So that might be something we talk about and look at the number specifically and just check in to see what that's about. And thank you for sharing. That was so brave.
So is the SHBG the carrier?
It is a transporter. Mm-hmm.
So these numbers are saying that she has a lot of transporters, but not a lot of particles to transport?
No, good question though. It is that she has a small amount of testosterone, and of the testosterone she has, it is stuck to the transporters. And so the problem is she doesn't have any free testosterone. Free testosterone is the one that can actually go do stuff and help us with the bone density and all the energy and motivation and things like that. Any other questions?
What's a target for free testosterone?
7 to 10. So total testosterone 70 to 100. Free testosterone 7 to 10. Yes.
I remember asking my PCP about hormone testing a while ago, and she said that typically it's useless because it just takes a snapshot from that one particular day, and so it's reflective of where you are overall.
Yes. Yes. Sorry. So the question, yes, the question was, I have to repeat for our online people. The question was, your primary care will often say, hey, the labs you receive are just a snapshot in time.
Do them because she said they were useless to do them because they would have been.
And mine wouldn't do them either because they said that unless I'm experiencing enough symptoms, that they wouldn't run them.
Okay. So to echo, primary care doctors are refusing to run the hormone labs for these beautiful ladies because it's only a snapshot in time and or you aren't symptomatic enough, and then you agreed too.
Right.
Right.
And then she also said, well, your ovaries are done, so there's really no reason to do this. There's no reason to
And they're hearing, oh, yes, and they're saying your ovaries are tapped out. What's the point? Yes.
And migraines. The migraines is what I wanted
Help.
to
Yeah.
help with.
Yes.
Isn't a snapshot of what your body's doing on an average day
A good thing?
idea of what it's doing?
Yes, yes,
Unless
absolutely.
you say where you partied really hard the night before, or you starved yourself for a week or something.
Yes.
I think that a snapshot of your average day would be what you are.
Right. And so once again, for our listeners online, she's just saying, well, wait a minute, isn't a snapshot in time exactly what we need to know? And that's my approach as well. So a big thing, so we have two things we're marrying together for our hormone patients here. And it is symptom picture, what is going on for the person. And I need that snapshot in time because I'm sorry, her testosterone would never go from basically 0 to 70 by herself without intervention at this age, knowing what we know. And we gotta have serum values to tell us where we're starting. And I'm gonna share a personal thing. After medical school, I was around, 28. And I was training under a physician who worked for doTERRA or Soda Pele. They're sort of the pioneers of pellets and really made them come back to life in the early 2000s. And I wanted my labs run because I'm learning how to do this for patients. And I went to a primary care and said, can you run these? And she said, well, I don't even know what I'd do if your DHEA was low. And what I want you guys to remember is that often, especially in an insurance ruled moment, they are obligated to follow protocol. Thyroid hormone protocol is you run a TSH and a T4 and that is it. Well, those don't tell you even a sliver of the pie. So we just have the superpower of freedom being not an insurance ran office, but also I really think that, and this is sort of mean, but I think it's because they don't know how to fix it. So they're not going to run it because they don't know how to fix it. And that's their brush it off thing,
Do the numbers fluctuate greatly over the course of your cycle?
Yes.
Does it matter where in her cycle you took?
Yes, thank you for asking that. Yes. So we actually waited until she was at day 21, which usually is 7 days after predicted ovulation. So because the release of your egg is part of why progesterone elevates. So a big piece of the puzzle for Chelsea was, hey, my periods are all over the place right now. And so when you're still menstruating, yes, it matters. But if you have stopped, we can run it whenever.
What if you had a hysterectomy and you're not sure where you are?
Any day is great. Yep. And also, once you're not once you don't have a menstrual cycle anymore, I'm predicting your hormones are so low and depleted, like we're gonna catch little glimpses.
You still have your ovaries, then you still basically have a cycle, right?
You do, yes, you do, but you don't at the same time. Yes and no. Yes. I feel like the only other thing I wanted to talk about with her blood work, and then we can move to primarily question and answer, was the balance of the 3 estrogens. Okay. Did anyone know you have more than one estrogen? Okay. So we have estrone, E1, estradiol, E2, and estriol, E3. Okay. We find that estradiol, E2, and estriol, E3, are what are protective to our breast and uterine tissue and so on. E1 or estrone can usually wreak more havoc or cause some of the cancer related estrogen issues, blah, blah, blah. And so I always run all three on my patients. So we have estradiol at the top at 238. Then I move on to her estriol, the E3, which is less than 18. And then her estrone is 98. Okay. So what I want is E3 and E2 to be higher than E1. Now, where I run into issues for patients is when they go to the GYN doesn't run any labs whatsoever, and they put the patient on an oral estrogen. Do not pass go. Very big, makes me angry if I'm being honest. And I did this week. I ran the labs on a different person. Her estrone, E1, the bad one, or not as optimal one, was 900 because of the way her body took in the estradiol, metabolized it through her liver, and converted it to the more not optimal estrogen. Now, E1 has function in the body. It's valuable, but too much, not so good. But what we do at our office here is we do transdermal applications. So maybe a patch, maybe a cream, the hormone pellets. You could also do injections, and that bypasses the liver metabolism. It makes you less at risk for the estrone going too high, and it also protects your breast tissue. We've proven that estradiol supplementation via the transdermal method is safe and healthy for our breast tissue, and helps with bone density and so on, versus the oral administration that puts you more at risk for blood clots and causing those negative symptoms. I kind of got jumbly there, but does that make sense? Okay, so anyways, that is that. The last piece of the puzzle is her little adrenals. So when we wake up in the morning, and we can totally go back to the sex hormone stuff. I just want to finish this and then we have free talk, okay? So when you wake up in the morning, your cortisol goes up. You have energy to do your day. Around 3 o'clock, it tapers down and you start getting sleepy. That's when we run for a coffee or a sweet treat because we want our cortisol back up. And then it goes nice and low in the evening, and then melatonin goes up and it helps you sleep. For my high functioning, over the top, overachieving, amazing women who like do yoga for the football team and everything else, I expect her cortisol to be actually compromised a little because these are my high achieving humans sometimes get a little burnout from doing a lot. So sometimes, right. And this is also your I can't live without coffee people, which I am one of, admittedly. But anyways, so we wanted her cortisol to be a little bit better. We wanted it to go up a little higher, maybe closer to 12. So we talked about doing some adrenal support. And then we also look at her DHEA, which is another hormone from the adrenal that acts as the buffer to cortisol, and it serves as protecting the immune system. And that is sort of the key with that, which reminds me, I feel like we need to talk about the adrenal supplement because now I feel like I missed that on our treatment plan.
Yeah.
Okay.
Yeah.
We
talked about it. It wasn't on it.
Okay. Got it. Yeah. I will update that. Thank you. Okay. And that is believe it or not, a summarized version of the lab review. And so that's that. So in the end, for Chelsea, we're going to be doing a 100 milligram progesterone supplement at night. And I say supplement, meaning we are supplementing her progesterone, but she's going to go through like a compounded pharmacy. So she'll take that at night, helps with sleep quality, and we're hoping to help control the uterine bleeding with getting that progesterone back online for her until she moves into menopause. And then we need to start thinking of, do we need estrogen replacement and getting that online as well. We're going to do a little bit of testosterone cream that she'll put on every day.
Where do you put it?
Good question. So you want to put it, this is kind of funny. You have to put it where you're not going to touch people. Because what if you just like start rubbing your, you know, you don't want to hold the dog and get testosterone. So I actually recommend you put it on the inner thigh, and you can actually put it on your labia, which is interesting. Because if it does encourage some hair growth, like we have hair there.
Yeah.
So, and upper inner arm. But I usually recommend thigh.
Yeah.
Yeah.
So I feel like with my kids and stuff, I would.
Well,
I don't
and
know.
if you're in tank tops
I'm
and stuff, that's
oftentimes in a tank top.
yes. So that we have to kind of put it where you won't have it.
Inner thigh.
We're going to put her on vitamin D and K too. So vitamin K is instrumental in absorbing the vitamin D. So she's going to do 10,000 IUs of that for 6 months. We're going to put her on selenium and iodine, and then we are going to put her on a little bit of DHEA just to give her some adrenal support, and an adrenal supplement with adaptogenic herbs in it that say, hey, you are a go-go gadget kind of gal. We are just going to get you a little bit of energy support to make sure those little guys don't tap out prematurely. And that is sort of the end of your lab review.
Yeah.
So, do you have anything or thoughts or ads?
I just find this so fascinating. And I love that we're looking at like the entire body system, not just this one symptom that I'm experiencing with like some sort of smaller symptoms that maybe could be from something else, but it's like to be able to see everything. And then I was telling Dr. Holt, I love too that it's not like, here's a prescription, that's it. It's also like supplements and other ways that we can kind of support optimal feeling without it being all just prescriptions. So I'm super excited to try this and see how I feel.
Yeah, me too. Yes.
We have an online question. Which estrogen does birth control fall under?
So that can fall on. What the question was, what type of estrogen does birth control fall under? And the unfortunate thing is it can be oftentimes synthetic estrogen or progestins. So those are not what we call bioidentical hormones. When you do hormone replacement therapy for the purposes of menopause and perimenopause, we are using estrogens that look exactly the same as what your body makes. Like they're a mirror image. Estrogens for birth control, unfortunately, are taken orally for these young females, and they are sometimes synthetic, but they can also be in the form of estradiol, estriol, and things like that. It's just at doses that kind of tell the ovary to go to sleep. And the reason why they're still utilized for young 20-somethings and 30-somethings is their blood clot risk is lower. They actually have a higher chance of blood clot during pregnancy than they do from the pill. However, as you age, that totally changes, which is why I hate birth control as an option for a 40-something. Next question.
So back in the day, my mom had breast cancer, and they wouldn't put her on any hormones because they're like, oh, the cancer's going to feed on it.
Yep.
Is there anything that would make you not a candidate for some of this?
Yes. So there is one. So repeat the question. Oh my gosh, I'm the worst. So the question was for a family member had breast cancer. Their doctor said, we're not putting you on estrogen ever. What do we do for those patients? So there's a specific type of breast cancer, which is estrogen receptor positive cancers, like the BRCA, you probably heard of. And those are patients that we're like, we're just going to really be mindful, maybe not put them on it at all, and only do testosterone replacement. We find a lot of the symptoms we experience are actually mitigated from testosterone replacement. However, for all the other cases, and there have been unique times where a patient with a cancer history does go on therapy once they've resolved, because let's say you have the hysterectomy and the ovaries are removed, you're all of a sudden without any of your hormones and you're completely suffering. So the key is we make sure you're doing estradiol and it's not the synthetic form. We're doing bioidentical, and the route of administration matters a lot here. It's that transdermal pellet or cream that makes it safer. But it's good question. So she was asking, what are the hormone pellets? So hormone pellets are little tic tac size things that look like a tic tac, and I surgically place it under the skin on the glute, and that hormone stays in the body and dissolves. So that little pellet dissolves over time. Your body builds a blood supply to it, and it gives you a steady amount of hormone over a 3 to 4 month period. Then we think about cream. Well, cream is giving you a daily bump, or an injection is like a week. So you have different options. We usually, for folks interested in pellets, I love them because it's giving you a consistent blood supply over time, and you're not experiencing highs and lows and highs and lows. Yes.
How long can you do the pellets for?
How long can you do the pellets for is the question. Truly until you die. Like, there is no time frame. There are some who say, oh, there's only a small frame of time that it's safe and blah, blah, blah. That is old news, old science. And a lot of providers in this space, we call ourselves like the functional medicine anti-aging space, because it's so protective to your health. You can do it as long as you're wanting to participate.
And do you do the pellet in the same spot for years and years and years over and over again?
We rotate around, yeah. And then there's also, which was part of the training I did with Dr. Pete, is they've come up with a new, less invasive way to put them in, where the device itself is blunt at the end. And the benefit of that is I'm not like tearing through tissue to get to where I need to go. I'm weaving around structures to place them gently, and that creates less risk of scar tissue. So, anything else? Yes.
How often do you suggest getting labs? Because I had labs a year and a half ago. My guess is I would have to get them again. Is that, or after 50, I have to get them every 6 months? Is there a sort of a prescription for how often you should be checking?
Yes. The question was, how often are we checking labs? So for a new patient visit, so first and foremost, I would definitely want labs again. I need labs that are within the last year to 6 months in order for me to get a gauge of where you might be now. If you choose to go on therapy with us, what we do is an initial lab draw, which is this big juicy panel. And then after we put you on the therapy for so much time, we do little panels to just check in, like, okay, she did a pellet. We want to see how high her values are. We check in 6 weeks later, blah, blah, blah. And then after that, once we get you in a sweet spot, we usually don't need to do it for until annually. And this is your optimal health progress report card. I want you to hang it on the refrigerator. And if we see where your values are when we start, let's say we're working on estrogen, but also your cholesterol, I want that opportunity to see, hey, we made it better, so. And it kind of varies. Some of my patients want to see it every 6 months just because they want to. So, anything else? Anything from online? Oh, Catherine?
So, Chelsea, this is for Chelsea. When you left after she went over everything, and sort of what was your thought?
Yeah.
Leaving, like your impression, your thought, and what will success look like to you?
Yeah. Well, I think, and I don't know if I said this at the beginning, but I definitely, my patient profile maybe is a little bit different, but my goal is really to feel optimal. So I'm thinking about, and that's how I think about my whole life, right? So these like choices that I make are small but consistent and steady with like how I'm eating and how I'm moving, and trying with stress management, which I'm not doing a great job at right now, but it's on my to-do list. So I was really hoping to get information about how we can kind of mitigate these little symptoms, but also just like, I want to be educated about how my body's functioning. And I think especially for the phase of life that I'm in, like I know that having a baseline now is going to be valuable for moving forward. So we have information as symptoms change or as things come up, we'll be able to kind of refer back. So that was a big priority for me. I would say, I mean, I felt very well informed. To me, that's valuable. Like I am someone who wants all of the information. So I loved, I mean, I don't know how long we went through labs, but I was like asking tons of questions, like every single thing. I was like, what is this? What does this mean? I also am like a perfectionist. So I was like, if anything was in the red zone, I was like, what do we do to get me out of the red zone? Which it also was very helpful to have someone say, like, this is not a particular concern. I'm not that worried about this, but this is something that I do think is really based on my symptoms, my health history, what my goals were. I feel like it was like a very comprehensive view, and it wasn't just the numbers, which was helpful because I was getting a little caught up on some of the numbers that I probably didn't need to worry about. So, I mean, I'm excited. And like I said, I feel like having kind of a blend of, you know, we're trying some supplemental things that are hopefully going to make changes that aren't, you know, a prescription or anything huge, but could make a big difference in the way that things feel. So I really like that it's like a combination. I feel like the treatment plan is a great example of like the broad and holistic approach of like treating the whole body from multiple ways. So yeah, I felt super excited about it. And this was very recently, so I cannot report back on what's happened, but I will definitely report back because I'm totally an open book with all of this. So yeah, I thought it was great. I feel way more informed. I still feel like I need to learn more, but I'm excited to have a resource to be able to come to because I'm going to have a lot more questions.
Yeah, speaking of resources, a book that circulates conversation a lot that I recommend on Audible or picking up is called Estrogen Matters. And it's just a nice overview of some of the things we spoke on this evening that just sort of like go over some of the scares that estrogen had in the past and how it's all been really debunked and how we need it and how protective it is for us. So if you're interested in just a light reading about chemistry, just kidding. I've heard very good things. I'm actually need to get a copy for myself too, but yeah. Any other questions? Yep, no.
How long would you expect sort of improvement, or does it matter what areas you're seeing deficits?
Yeah, I don't know. I don't remember how to say what you just asked. How long does it take to see results? Is that kind of the question? Okay. So for hormones to start kicking in, depends on the route of administration. So if you imagine I surgically place a pellet under the skin, right where there's blood vessels, your body's going to build a blood supply to that. You'll start feeling changes in 6 weeks, but the full benefits take 3 months. So it's a slow burn. You're not all of a sudden hopping off the table and like ready to have sex, you know, it's like gradual. But transdermal cream is a way more gentle ride because you got to remember it has to go through the skin and then into the bloodstream. So the answer to that is kind of dependent on what we choose to do. However, in general, 3 months is sort of the main answer. And then I say, give me a year to work with you because we're going to fine tune each time we connect. I am on email with my patients. I am touching base and following up on phone calls. We're doing in-office visits. So it's a very hands-on experience to curtail it for you because, you know, are you here to cut me off? I'm just kidding.
What does going on this journey mean for longevity? and the way, sort of in general, I mean, everybody wants to feel better in the moment and that kind of thing. But do we feel better and live longer? Are we healthier?
Yeah, and oh my gosh, so sorry. I'm so sorry.
That's why he's up here.
I keep forgetting to repeat the question. So the question was, what does this mean for longevity, health, lifespan, and disease prevention and things like that? So the immediate results, of course, are no longer do I have a hot flash. But you have to remember, like, what fractured bone leads to death in old people, like very old people?
Yes.
Hip. You freaking fracture a hip and you're done for. It's like wild. But what if you're on estrogen since 55 and your bone density is awesome and you didn't need to take Boniva that wrecks your GI system? That is a great example of that. They also have shown it helps prevent things like Alzheimer's. It's protective to the brain. Once again, cardioprotective. So I can't personally quantify, oh, you'll live 20 years longer. But what I can stand by and hold, my head up with pride is these panels are way more than most people get, and you're going to be getting them sooner than the problem. We are not in reactive medicine. We are in proactive medicine. So you're looking at your cardiac inflammation and your cholesterol and your insulin resistance now before it's an issue. And usually it spikes you to get your husband in, and then his health improves. And it's just like the whole comprehensive approach. Do you feel like that answered that?
Yeah, I mean, it's being better, and then by being better, those things that creep in with age don't creep in.
Yeah.
The same.
Yes. And imagine you feel better, so you have more energy, and so you're getting 10,000 steps a day versus feeling joint pain all the time, wanting to be sedentary, and then it's a cascade. So my objective is just to help people feel their best, then they go do life. And that's pretty powerful, because a lot of people, I always like to say, you do not know how good your body is designed to feel. Although you all look really healthy to me, so I don't know. Yes.
And you don't go through insurance for health insurance or anything?
Unfortunately, no, but we do in the sense that we make it as we do what we can with what you have. In like for your labs, if your labs do cover insurance, we can go through Quest instead of the other lab, and then that way that is taken care of. If you prefer to have your medication through your pharmacies like Rite Aid, I can figure out getting a hold of an estradiol patch, because I know they have that there, and that might be covered under your insurance. So we do all we can to make it work. Mm-hmm. Yes.
So if you have more than one of these symptoms or issues, like say your testosterone, your progesterone, and your estrogen are all off, is there one you like start with, or is there a hierarchy, or do they all work together and you need treatment for all of them? Or?
Yeah. The question was, if you have several values of labs that are off, do you address just one or all of them, or do they work in synergy? And they actually work. They do work in synergy. It's best if we do all of them at one time. If that's what you need, it depends on if you're still cycling. Are you only, what is your health history? Is there a breast cancer history for you? And so it's a very individualized thing, but in general, we want to treat it all and not leave one out, because they work together. Anything else? Okay. I think we can
borrow the mic.
Yeah.
Well, first and foremost, I'd like to thank all of you who stayed. Not a single person nodding off. Everybody totally engaged. It really was amazing, and you can see how important this is to you. Secondly, thank you very much, Chelsea, for bearing your soul in front of everyone.
Everyone knows everything
Yeah.
about me now.
Yeah. but especially thankful to my number one here. I mean, I think you all know she's so smart, but so approachable, knows her subject matter like nobody's business. And I don't know why everybody in this room wouldn't want to come have her do a little evaluation. So,
Is she taking patients? That's my question.
oh, yes. Yes.
Yes.
We don't do this for nothing. So.
Yes. Here, let me take one.
I think that's the other concern in our community is doctors that are taking patients right now.
Yes. And to my understanding, those who attended the live event are eligible for receiving a discounted rate for a consultation. So that is something we will reach out to you for. If we, on your menopause screening questionnaire, I would really love it if you just wrote your first and last name and phone number, and we will just return those. Yes, it's the $100 off coupon. Yep. And just write your name and phone on there. That way we can bother you tomorrow. No, just kidding. Yay, thank you.
Thank you.